Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about rheumatoid arthritis. It's a very, very common medical problem. In this country, 2.1 million folks suffer from rheumatoid arthritis. It is 2 to 3 times more common in women than in men. Worldwide, there's about 40 million folks who are suffering from rheumatoid arthritis. As you already discussed in the previous two shows, that it affects a systemic disease. It affects all part of the body, but mainly the joints. Again, the joints are the hands, the ankle, the knees, the shoulders, the neck, the feet, the fingers. Just any joint is affected because it's an autoimmune disease. What happens is that you will have antigen antibody complexes that are formed. Nobody knows why that happened because we still don't know the cause of rheumatoid arthritis, even though it's been around for a couple of hundred years. But once those things are formed, they get deposited throughout the body. Talking about the joints in particular, once they get the antigen antibody get deposited in there, by necessity it creates an inflammation. It is the inflammation that it creates that causes the damage to occur in all the joints. And for that matter, from the brain all the way down to the toe, you could have problem with it, all organs. And the list of organs, of course, as I mentioned, the heart, the lung, the brain, the blood system, the kidney, the skin, the neurological system, the spleen, the liver, the gastrointestinal system, etc. It's a very common problem. It's a very painful disease. There's basically no cure, but there are, of course, treatments. And in this segment, I'm going to concentrate mainly on about treatment because the last two shows, I already went out of the basic, the detail, etc. We are now, the diagnosis has been established. I'm not going to bore you by going over them again. It's very complicated when you are evaluating somebody who you suspect have rheumatoid arthritis based on the symptoms and the physical examination. You must, by necessity, also evaluate other conditions that are on an arthritic nature or inflammatory nature that may be associated with the rheumatoid arthritis. Because if you have one autoimmune disease, which rheumatoid arthritis is, autoimmune slash inflammatory disease, you live long enough, you're likely to have one or two more. So every time you see that, if you even start treatment, you have to make sure that it is only rheumatoid arthritis that you're treating, that there's nothing else associated with it, okay? Because there may be, and the list of things that can be associated with it, other diseases, scleroderma, psoriasis, and so on and so forth. All these things, you have to rule them out in the process of evaluating when you do your blood tests, your x-rays, etc. Now that you've done all that, you're dealing basically with rheumatoid arthritis. Well, it's an inflammatory slash chronic disease. What do you do? Well, it's an autoimmune disease. You must then begin to, first you try the most common medication used in the world to treat rheumatoid arthritis, of course, is aspirin. Why? Because aspirin is the cheapest that medication people across the world can have their hands on. 142 million people, 140 million people have it across the world. And in the developing world, where they really don't have the money with which to pay for something like NSAID, for instance. So they try aspirin. Okay, now, what dose of aspirin? Well, you're talking about 325 milligram aspirin, one pill. You got to take two of those 3-4 times a day. That's a lot of aspirin. And of course, the problem is that it can cause you to bleed. Because if you take aspirin for that long, you're going to wind up with gastrointestinal bleeding. In addition to that, there are many other conditions that will contradict you from having to take the aspirin. So if you're not in a developed world where you're being evaluated by a very academically sophisticated doctor, you may have bleeding problem that you don't know anything about, okay? Such as, von Willebrand disease. Some 70 million people across the world suffer from von Willebrand disease. It was a qualitative platelet problem. Well, you can't touch aspirin if you have von Willebrand disease. So before you get treated for it, the doctor would have already known, assuming we're talking about someone who really up to date in the 21st century type medicine, he would have done some tests such as PT-PTT that would have raised the red flag. If the PTT is elevated, well, then you're forced to check the patient for not only van Willebrand disease, but also for hemophilia. Hemophilia A, hemophilia B, the PT may also be elevated. If the PT is elevated and the PTT is not, well, you're talking about other conditions, other factors, such as factor 5, for instance, that when become elevated, the PT may become elevated. So this is very crucial thing. So very frequently people showed up in an emergency room, even in this country, for a variety of reasons. And the first thing they will do, doctors or nurses, whoever is involved, nurse practitioners, will give the person an aspirin. Well, you have to be very careful before you give somebody aspirin, because you have to first do your platelet, because if your platelet count is low, you do a CBC, the platelet count is low, well, aspirin is contraindicated. And the platelet count may be low for a variety of reasons. ITP is one reason. And so, I mean, the list is quite long, okay? So I'm making the point, as important as it is for these folks to take the aspirin because they're in pain, they may also be hurting themselves if they have underlying conditions that they know nothing about, and then they're going to start taking aspirin. Because once you take the aspirin, yes, it is anti-inflammatory medication. It's also anti-pain medication. It's also an anti-fever medication. It's fantastic medication. But you got to be careful, super careful, that you're not going to, even if you have none of the associated conditions that I mentioned, the fact that you're taking aspirin for a long time, it is inevitable. You're going to wind up with upper GI bleeding, because the aspirin itself, as it rubs itself against the wall of the stomach, you're going to wind up with bleeding. It's inevitable. That's it. But what can people do? They're in pain, and they don't have the money to pay for other things. So then let's go take a look at the NSAID, which is stuff like Motrin, Aleve, Advil. These are all NSAID. Great medication. Problem is, you just cannot take them unless you first make sure you don't have any one of these underlying conditions that I mentioned to you. If your platelet is low, you take an NSAID, it's going to cause you to bleed. The only difference between the NSAID and the aspirin lasts 7 to 10 days. The effect of the aspirin lasts 7 to 10 days in the human body. But the NSAID, the effect of the NSAID on platelet, for instance, is only 6 hours. But 6 hours can be crucial. Let me repeat that. The effect of, because a lot of times people are going to the OR as I speak, people are going to the OR. In fact, today I have 2 patients going to the OR as I speak to you right now. You have to prepare this patient. You, the internist, have to prepare the patient for the surgeon that's going to do the surgery. One of the things you're going to do, you're going to do PTT, you're going to make sure the patient is not going to bleed, okay? So you got to be very, very super careful. Well, people are in pain, they're going to take the NSAID. If you have kidney disease, it's very problematic if you take NSAID. It's going to make the kidney insufficiency worse. Okay, if you have kidney failure and you are either on dialysis or not yet on dialysis, but kidney fail and they're planning to dialyze you, you got to be very careful, because the very fact that your kidney has failed itself, not only that the NSAID can affect your kidney to make it worse, but the fact that your kidney itself has failed or is failing causes you to have qualitative platelet abnormality. Let me repeat that. Yes, if you have partial kidney problem, kidney insufficiency, you're an elderly person or whatever, you take NSAID, it's good for you, it relieves the pain, but you have to be careful. It might make the kidney problem worse. But when the kidney fails, you're giving somebody NSAID who has, you can't have kidney failure. That's the point I'm trying to make. You can't have kidney failure for which you're either being treated, not yet being treated, without having qualitative platelet abnormality. I'm not going to bore you to go through all the detail with the academic reason that occurs. I will just simply mention to you the fact that your kidney has failed. There are certain substances that must be excreted out through the kidney. You can't do them properly. So they're piled up on top of the platelets. How about that? So that automatically creates a qualitative platelet abnormality. And that is a contraindication to take an NSAID. They say, well, Val, what can people do? You have everything they can do. Well, listen, my job, my responsibility is to make sure the medication that you're being given that I and others are given, number one, it's going to do the job it's supposed to be done, and it's not going to hurt you. It's not going to hurt you. If it's going to hurt you, then you shouldn't take it. You look for other stuff. Okay. So, NSAID is another one. Okay. So you use aspirin, you can use NSAID, and then rheumatoid arthritis, when it is acutely swelling, hurting you, you got to use steroid, corticosteroid. Okay. Crucial corticosteroid. Why is it that I'm making the point how crucial corticosteroid? Because it's an anti-inflammatory medication. It has a lot of values, but one of the things that it does, it blocks the inflammation from, it dislodges, as it were, the antigen and the antibody that clogged up together, and it's going to cause you to have an inflammation. But the prednisone and any other type of steroid, being it IV or subcutaneous, whatever, is going to find itself in between those things, dislodging them. And then also it is itself an acute anti-inflammatory medication. I was saying to someone recently, we're living in a world right now where black folks are being brutalized all over the place. There are people who think they're better human beings than black folks, Negroes and slash black folks. Look at this example I'm going to give you to make you the contribution that some Negroes have made into the world. Who created, biosynthesized, as it is the proper word, corticosteroid? It was a Negro, Dr. Percy Julian, who lived and died right here in the town of Greenberg. When Dr. Percy Julian graduated college, I think it was DePaul University, he desperately tried to get into a PhD program. He was a biochemist. No school in this country will open the door to allow him to do a PhD because he was a Negro. He had to go all the way to Scotland. To Scotland, you can't make this up, to go all the way to Scotland, Edinburgh University, whatever, / and Coston, in Scotland to get his PhD. And when the man came back here, of all the great things that he did, one of the great things that he did, he created corticosteroid. Now, nobody, even the people who are using steroid for different things as I speak today, doesn't even know who Dr. Percy Julian is, because he's a Negro. Okay? If he were not a Negro, his name will be all over the place. He will be a giant of everything. Yet, of all the dozens of stuff that he created, corticosteroid was one of them. And I'm here to tell you, as a hematologist, medical oncologist / internist, there is no profession, no subspecialty or specialty in the field of medicine today throughout the world would exist, would be used properly without the need for corticosteroids at one point or another. Classic example, of course, is rheumatoid arthritis. The field of rheumatology wouldn't exist, the subspecialty wouldn't exist, because one of the number one medication they're using every day, 24/7, one form or another, is corticosteroid. Ophthalmology, fantastic subspecialty, couldn't exist without the steroid drop they're giving you after you have surgery or whatever issue with your eye. I can go on and on. Asthma, one of the number one medication in treatment of asthma, corticosteroid. And the one medication in the treatment of COPD, corticosteroid. And then one medication in the field of dermatology, corticosteroid. I can go on and on, okay? Even cardiology, when certain things happen to the heart, you got to use corticosteroids to decrease the inflammation. So, and yet, we are now talking in the middle of a racist situation that exists in this country that's finally brought to light. And yet, I'm here to tell you, it was a Negro gentleman who did this. Years from now, when I'm dead and gone, I hope that somebody will have enough decency to also mention the stuff that I have done. You don't have a single physician today in the 21st century in this country or across the world that have done more, that have contributed more to the present day field of medicine than I have. Okay? And I'm not being arrogant. I'm not saying things that's not proper. It is accurate. You could check it on Amazon if you want to. Okay? Stuff that I have done that are helping hundreds of millions of people across the world as I speak. I didn't do it for money. I didn't do it for fame. I do it to make contribution. Which brought me then to the medication that I'm about to talk to about. It's a medication called methotrexate. What connection do I have with this incredible, important medication that are being used throughout the world to treat rheumatoid arthritis? It was the first disease that, besides cancer for breast and cancer for childhood leukemia, this was the first medication rheumatologically that was tried in the world was methotrexate. How did that happen? Well, I'm sitting right here talking to you. I'll tell you the story because it's rheumatology. Besides, this is my show and I'm telling the truth. I was a medical technologist in New York City. Thankfully, New York City decided everybody who works in the lab had to be licensed. So I became a laboratory technician because I took the course when I was working in a factory, blah, 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 blah. And so every Saturday, I would walk in without studying and take this exam and pass them. So I wind up with 7 separate licenses to work in the laboratory. So everybody obviously wanted to hire me because I have those licenses, everybody, because those licenses allow me to supervise, to work or whatever. So I got a phone call from Brookdale Hospital in Brooklyn. And I was interviewed. I had my license. I was still in college and high school simultaneously, going to college and high school. And this gentleman hired me because he wanted me to help the doctors, the 2 physicians, hematologists in training that was under his tutelage, how to set up the research project. Because in those days, when you go into hematology training, you have to do 1 year clinical, 1 year research. Those 2 gentlemen had absolutely zero interest in doing research. They were just coasting along to finish the year. The gentleman who hired me, who was really my boss, realized what was going on. He never said anything. If he did to them, I had no privy to it. He just came to me one day and said, Val, you could do your own research if you want to. I said, are you kidding me? He said, yes, you could set up any research you want to, because I was the one ordering the animals and the different things, whatever. So out of the blue, from the top of my head, never even know how to spell the word research properly, reasonably, seriously. I'm not joking, because I'd never done research before. I set up a research project using this flask that was full of this yellow powder. That yellow powder happened to have been methotrexate. In those days, we didn't have liquid medications. Everything was in powder form to dilute them with saline to give it away. So God said, pick up this yellow thing. And I won't bore you with the details on how I did it, because look at, as a matter of fact, this big book here, The Art and Practice of Modern Medicine, right here, I described the whole project, how I did it. So I did the research, and the research showed, what I showed was that it's powder that I diluted, and I give it to 2 separate groups of 24 mice. One group of mice I didn't give the methotrexate to, but I just had some powdered material, diluted it, and inject both group of mice, 24 control, 24 research with this powder material. That's the antigen, all on my own. Then I decided to dilute down some of that methotrexate that I just mentioned, the powder, some with normal saline, and I give one group of mice through the tail. You warm up the tail, the vein popped up. I give 24 of them a little bit of that methotrexate dilute stuff. The other group I didn't. Okay? So that was the control group. And of course, I waited for 7 days. I bled the mice to the corner. There's a hematocrit tube. You could suck up the blood. So I bled each one of them from the corner of their eye. So I got 24 control, 24 research. And I spin them down in the centrifuge. And I had what you call haptolenic plate, little plate that has little jello in it, white little jello. We don't see them there anymore. It was not Petri dish, it's haptolenic plate. Then I spread, the diluted plasma on 24 of those little plates and 24 on the other little plate. Turns out that the plate that had the methotrexate, I kept looking every morning, opened the incubator, nothing happened. Nothing. Stayed to this day, nothing. Nothing happened to those 24 little plates. They're still blank like that. You could see the little jello, white jello is there. However, the 24 group that I did not give the methotrexate to, okay, you ready for this? 7 to 10 days, I opened them up, and each little plate have this little arc like that. That is the antibody. In other words, the group that I did not give the methotrexate to, 7 to 10 days later, from the time that I put the plasma in there were those arcs. Each plate has multiple little arcs in them. That, my friend, was the antibody that was produced. However, the group that I give the methotrexate to this day, remain empty. That proved the fact that, number one, methotrexate blocks the production of the antibody. That was it. That created my life that helped me to become a physician. Everything happened from there. So when I sat my boss down, first of all, it shows one more thing. It told the world that if you get a vaccine or anything else, it takes 7 to 10 days for you to develop antibody. The world knew you developed, they didn't know the days. Now they just found out 7 to 10 days. The world did not know that before, that's true. They know you would produce it, but they didn't know the exact days. Now you know 7 to 10 days. So when I sat my boss down, explained the whole thing. This happened at Brookdale Hospital in Brooklyn, East New York. I don't know that Brookdale ever get the full credit that they deserve for this, because soon thereafter, I sat my boss down and talked to him about this. He said, "You got to be kidding me. You did this?" I said, "Yes." He said, "Val, it takes a genius to do something like that. I got to get you into medical school." His word. His name is Dr. Tobin. And he wrote me a letter. I took the letter, mailed it to Harvard. Then I took the letter to Queens College, where I had transferred to be a pre-med, to Dr. Daniel Marion. He passed away, fantastic gentleman. I showed him the letter. He said, "You got to be kidding me." So he packaged me, Dr. Marion packaged me, made an arrangement for me to go to Einstein for an interview. Because he was the pre-med advisor. Every year, he always had one of his 2 students get accepted at Einstein. So that was 1968. Gentleman packaged me, sent me over there, and sure enough, the 12 people that were interviewing me, they were all basic scientists. And I brought all my research paper. They were blown away. Blown away. I know it's a street word, but they were. They were so impressed, and I was accepted on the spot. So I went to Einstein in 1978. The gentleman from Harvard came in and interviewed me at the Waldorf Astoria on a Sunday morning. Literally, this guy is almost about big 6-foot guy, 6'7", whatever, pleaded with me to come to Harvard. I said, "I'll think about it." And of course, I didn't go to Harvard. I wound up at Einstein. So I went to Einstein 1968, and I graduated college in 1970. And the rest is history. So and then once the paper was published, throughout the world, they started trying methotrexate in human. Hence, the use of methotrexate as we speak for the treatment of rheumatoid arthritis. That's not the end of it. Because methotrexate has significant toxicity, years later, not through me, I don't know anybody else that I'm associated was involved in that, via DNA recombinant techniques, they went and the lab created all the biologic you see on television today. I had nothing to do with them personally, but I did the original work. That's how when you turn on your TV, tonight, today, whatever, you will see all the Humiras of the world, all these other incredibly fantastic medications that are being used to treat all rheumatological problems, psoriasis, Crohn's disease, on and on and on, ulcerative colitis. All that came out of this brain originally, though I did not do the biologic. They did it to bypass the toxicity of methotrexate, which is being used as I speak for all these things as well. And that's how yours truly wind up into medical school. To Einstein, I was already, what, I think I was 34, something like that. And the rest is history, okay? And when I get to Einstein, I was the oldest one in my class. And 20% of my class that I had to compete with were MD PhDs, 20%. And these people were so smart, they could teach the basic calculus themselves. Some of them never even bothered to buy the books. And I had to compete with them. With my class, you can get 90% on an exam and fail because it was a curve. And as I speak to you right now, these brilliant young men and women, I'm the only one graduated from that school since 1955 who has an M.A.C.P. What you see behind my name, M.A.C.P. Okay? So I owe a lot to Einstein, I owe a lot to Queens College, and I owe a lot to Dr. Tobin who give me that letter. Okay? So that's how I got to be a physician. That's how I got to do all the stuff that I have done that are helping hundreds of millions of people across the world. I'm the only physician who have written 31 books by myself from the top of my head. All these books. Here's the latest one. The best of medical oncology and clinical hematology. It just came out a few months ago. I wrote that on my own from the top of my head. Everything having to do with cancer, hematology, it's all there. Blood diseases. All that I did on my own. Listen, I'm stopping here. Until I see you again, this is Dr. Alcena saying so long and bye-bye.